I am Dr. Sandeep Suri, working as consultant physician diabetologist at Holy Health Hospital, Hisar, Haryana. And my working experience is 25 years. I'm going to share one interesting case from my routine practice and that I sorted out for discussion. He is a 58-year-old male with a present history of type 2 diabetes since last 4 years. He is obese, hypertensive, hyperlipidemic, also has got history of obstructive sleep apnea syndrome. And on physical examination, BMI is 32 kg per meter square, blood pressure 130 by 82 on medications, heart rate 60 beats per minute. Personal history is non-alcoholic, non-smoker. Family history is positive for diabetes. Elder brother has also had diabetes. Then younger brother is also having diabetes. Mother and father are not having diabetes. Lab investigation, HbA1c value is 8.5%. eGFR calculated estimated glomerular filtration rate is 70 mils per minute. LDL 69 milligram per deciliter. HDL 35 milligram per deciliter. So that means HDL is going down. Triglyceride is 250 milligram per deciliter. That means triglycerides are on higher side. eGFR 70 mils per minute. Definitely it is going down. HbA1c is not under control. AST, ALT when checked, they were 72 by 100. That means they are again on higher side. So, and what medication he is on? He is on metformin 1000 milligram BID, lisinopril 40 milligram OD, and then metoprolol extended release 1000 milligram BD dose, atorvastatin 40 milligram OD, and he is on ecosprin aspirin 75 milligram. So this patient profile says that he has got a shorter duration of diabetes, and that means around 4 years of duration of diabetes. He is young as per the age of 58. He is fully productive. He has got fully productive active life. He is well working in his business. He is not having major complications, but definitely 2-3 issues are there, like his eGFR is going down, NFLD is there, he is hypertensive, he is obese. So he is at low risk of hypoglycemia, definitely as per the duration of diabetes, as per his age. But we have to avoid hypoglycemia at any stage. And so let's find out the goal, that how much target we should fix for this case of getting glycemia under control. So looking at the patient scenario, age 58, productive life, duration of diabetes in shorter duration of diabetes of 4 years, but associated things like he has got hypertension, dyslipidemia is there, NFLD is there, eGFR is going down. So we have to fix targets, and also looking at very low risk of hypoglycemia. So we have to fix stringent target. So we cannot have liberal target in this case. So we have to go either to 7% or less than 7% or up to 6.5%. So we have to fix some target for this patient, and it should be stringent target, because any liberty if we show here in management of glycemia, then all those complications which have just started to come up in this patient, micro and macrovascular complications, they will just proliferate in this case. So we have to go with a very stringent targets. Either it should be 6.5 or less than 7%, but we have to avoid hypoglycemia at any cost. So that means presently he is on 8.5% HbA1c. So we want around 1.5% or even more than 1.5% reduction in HbA1c. So what do we want to achieve in this case? We also want, along with this glucometabolic benefit, we also want vasculometabolic benefit. That means we want a drug molecules which should have cardiorenal benefit. Presently he is on metformin, good dose, adequate amount, 2000 milligram OD dose. He is also on ACE inhibitors. Then also he is on beta blockers and statins and aspirin. So all these things are there, but still we want the molecule which we should use in this patient to decrease glycemia, to manage glycemia, should have added advantage of vasculometabolic benefit. That means cardiorenal benefits are required in this case. Third important thing, viscerometabolic benefits are required. He is obese. We want to reduce his weight. Around 10%, 5 to 10% of weight should be reduced in this case. And also we also want to have his waist circumference should go down also. That's how we can achieve benefit as his NFLD status and also he has got obstructive sleep apnea syndrome, which again it is an independent risk factor for cardiovascular disease. So that also should come down with visceral metabolic benefit. So definitely we require weight reduction in this patient. Then he is hypertensive. We also want that if there is something we can do with this patient to have barometabolic benefit, that means some drug which can bring his blood pressure, systolic and diastolic, to somewhat much better control. He has got 130 and by oblique 130 by oblique 82, and he is on lisinopril, but we want that something should be added to bring it further down. So what about recommendations? If we go to the recommendation, how to approach this case, ADA recommends less than 7% is reasonable goal for most of non-pregnant adults. In addition to efficacy, following consideration predominant in determining pharmacotherapy of this patient, such as risk of hypoglycemia, which are very low in this case, but they are to be avoided at any cost. Weight loss is required, and we have to minimize the weight gain. Then we have to also rule out incipient or subclinical heart failure or diastolic dysfunction in this case. We went for 2D echocardiogram screening in this case. Echo Doppler 2D scanning was done. There was left ventricular mass index increased. So this was also another finding that came into addition of thinking what type of molecule you should choose. Left ventricular hypertrophy, left ventricular mass index on higher side, grade 1 diastolic dysfunction, but left ventricular ejection fraction more than 50%. So again, he has got some issues related to his myocardium also. So heart is also at some point of significance has to be added here. Then we have to look at subclinical atherosclerosis in this case. So we went for ankle brachial index. It was 0.9%. It was 0.9 ankle brachial index, so that was normal. We went for ECG that was showing that there is left ventricular hypertrophy grade 1. So we had one evidence of left ventricular hypertrophy. Then we looked for incipient CKD in this case, because eGFR is going down. Let's look at microalbuminuria. That will have an added advantage in prognosticating the case regarding cardiovascular and renal outcome. So microalbuminuria was present. He was having albumin creatinine ratio of 250 grams per milligram. So that was also there. So then third thing important, we have to look at the cost of therapy. But the cost of therapy in this case was not an issue because he was able to afford the cost of the medication. But otherwise, we must pay attention to the cost of therapy because it's a long-term policy, long-term protocol. So cost of therapy should also come in our mind. So Mr. AB, who is willing to start another medication, but is concerned because he sometimes forget to take his pills and fears that additional pill will only make this worse. So he doesn't want to have more number of pills. He says, Doctor साहब और दवाइयां मत लिखना, ज़्यादा दवाइयों का बंडल मत देना मुझे. So he feels that he should have lesser number of medication. Number one. Number two, he doesn't want to have any injectable therapy. So GLP-1 receptor analog and insulin goes back to the back foot because of his not willing to start any injectable therapy at this present time. So that's how we also looked at his HbA1c. It is requiring 1.5% reduction from the target. So, and also there is no osmotic symptom, no catabolic symptom. So this patient is not, we should have tried to have better oral antidiabetic drug because he's only on metformin at present time. So he's a definite case for oral antidiabetic drugs. But injectable, yes, GLP-1 receptor analog can have all these benefits, but he's not willing to have injectable therapy at present time. So adherence and compliance is a big issue in this case because he often forgets about the pills and also fears that he will forget about the pills if you give a complex multi-drug therapy. So he requires sort of fixed dose combination. FDC will definitely going to improve his adherence to the medication because of their once daily dosing, and the regimen will become less complex, and fewer pills will be there, and there will be improved side effect profile and adherence. So we wanted to search about that fixed dose combination which can be put in this patient. So people with type 2 diabetes commonly live with multiple comorbidities, among which hypertension, obesity, and cardiovascular disease are most rampant and most common. Monotherapy cannot adhere these multiple defects and often lead to failure to maintain glycemic control over time. And we have seen in our approach of stepwise addition of medication, moving from lifestyle to metformin to addition of another drug, then another drug, then another drug, and the insulin comes as a last resort. So these stepwise approach was basically a approach for failure. That means every time you fail, and then you add another drug. So every time you fail with this type of stepwise approach. Now the current diabetes guideline, they encourage early adoption of oral combo therapy, oral combination therapy, which the molecules should have simultaneously emphasized the importance of individualized treatment, but the molecules should have complementary mode of action, and they should have they should not have any interaction with each other. Also, their pleiotropic effect should be intact when you combine them together also. So ADA recommendation is that in appropriate high risk individual like this patient with established type 2 diabetes, the decision is to treat with GLP-1 receptor analog or SGLT2 inhibitors in patients who have got established atherosclerotic cardiovascular disease. In is the first line of drug should be metformin plus lifestyle. Then you have to add SGLT2 inhibitor molecule or GLP-1 receptor and molecule, looking at their MACE reduction, looking at their hospitalization for heart failure reduction, looking at their CVD death reduction, and looking at their CKD progression. So the compelling indication of all these, having atherosclerotic cardiovascular disease established, multiple risk factor, also patient of heart failure, and also patient for going for CKD, these patients they require along with metformin, GLP-1 receptor analog if patient is willing for injectable, or SGLT2 inhibitor for oral antidiabetic drug, irrespective of the baseline HbA1c value. Even if your HbA1c is on target, but if you have got these compelling indication, you have to put these molecule, injectable GLP-1 or oral SGLT2 inhibitor, into the treatment portfolio, and you have to alter the therapy because these molecules have got benefit over and above their glycemia reduction. But another thing, that if you start, this patient is not willing for injectable therapy, so GLP-1 is out. So we should go with SGLT2 inhibitor. Okay, fine. Now, if you go with metformin BD dose plus SGLT2 inhibitor in this case, how much reduction of HbA1c is expected when you start as SGLT2 only in this case? It will be reducing your HbA1c by 0.7 to 0.9% to the maximum. Okay, if you start with sulfonylureas here, you will be reducing HbA1c by 1%. But there will be an issue of weight gain, and also there will be an issue related to hypoglycemia in this case. And if you start only with monotherapy plus metformin baseline with DPP-4 inhibitor, it will be 0.7 to 0.8% reduction in HbA1c. So you will be still off target. You want a molecule which should decrease HbA1c by around 1.5 or even more than 1.5%. So we went for a combination of Empalina. We went for a combination of Empalina because looking at empagliflozin individually, you have got very strong trial of EMPA-REG outcome trial that changed the whole scenario of management of type 2 diabetes. Secondly, you have got Emperor reduced trial. Now you have got Emperor preserved trial also. So all these data that strongly put this molecule into the protocols, that this molecule is to be given in patient who has got established atherosclerotic cardiovascular disease to decrease the risk of 3-point MACE, and also specifically to decrease the risk of cardiovascular death, which was only seen in empagliflozin with EMPA-REG outcome trial. 38% reduction in CVD was there. That is not replicated in other SGLT2 inhibitor molecules. So looking at this part, secondly, we chose about linagliptin. Now, linagliptin is a DPP-4 inhibitor molecule, and we have got two very strong trials to support linagliptin, as Carmelina trial, which was done in high-risk established atherosclerotic cardiovascular disease, established CKD patients, and these patients were, and it was an active comparator trial. So, and again, no, it was not active. It was cardiovascular outcome trial in very high-risk patients. And we have got Carolina trial, which was against active comparator trial, glimepiride, again in those patients who are high risk but not much established atherosclerotic cardiovascular disease, but very high risk and shorter duration of diabetes. So we have got very long, very broad bandwidth of safety and very broad bandwidth of utility of linagliptin in these type of scenario. On one hand, you have got patients having shorter duration of diabetes but multiple risk factors, and it was the longest trial, that is Carolina trial, and it was compared with head-on with glimepiride. On another hand, you have got a very high risk population of cardiovascular disease, cardiovascular mortality, heart failure, and also these patients were also in heart failure. CKD patients, 72% patients were already having CKD, and around 50% patient had CVD established. So atherosclerotic cardiovascular disease established. So that was Carmelina trial, and there this molecule proved to be CV safe. This molecule proved to be renal safe, but also it showed decrease in micronuria, and also it was very safe as comparison if you compare with other DPP-4 inhibitors in hospitalization for heart failure. Hazard ratio was 0.9 in hospitalization for heart failure in Carmelina trial for hospitalization for heart failure. In comparison to other DPP-4 inhibitors, it was very safe. So looking at these two molecules which has shown individual benefits, we tried to combine it, make a fixed dose combination of 5 milligram linagliptin and 10 milligram empagliflozin or 25 milligram empagliflozin. So this is a fixed dose combination. Again, the benefit is single pill, and it is OD dose has to be given. No dose up titration is required in this case, and this molecule which gives you immense benefit of cardiorenal protection on one hand with empagliflozin and proven cardio safety on another hand with linagliptin. Secondly, renal benefit with empagliflozin, and also renal benefit, renal protection somewhat, and renal safety with linagliptin. Then improving adherence of this molecule because of single dose, one time dose has to be taken, OD, and small pill, so adherence also goes up. And then it is an error-free combination. And what do you mean by error-free combination? Weight neutrality by linagliptin and weight loss by empagliflozin. So there is a definite weight loss when you combine this molecule because of their effect of empagliflozin. Also, blood pressure reduction is persisting when you combine it. So pleiotropic effects are persisting. Then per se, both of these two molecules are not having any hypoglycemia risk per se. So this fixed dose combination was tried here, and when you looked at glycemic reduction with usage of this fixed dose combination, it was 1.8%. So 1.81% reduction in HbA1c, and the trials are there up to 24 weeks that showed that patients who are on baseline metformin, uncontrolled HbA1c beyond 8.5 and beyond, 1.81% reduction of HbA1c was there, and the benefit was maintained. It was durable even up to 52 weeks of therapy. So that was a benefit, that you have glycemia reduction benefit. And also another important thing is that once you combine these two molecules, the chances of genitourinary tract infection, that was the issue related to SGLT2 inhibitor, comes down very significantly because of inhibition of enzyme, DPP4 enzyme, which is required for the growth of yeast and fungi. Okay, so that, and some bacteria also, that also goes down. So genitourinary tract infections are significantly reduced when you use this molecule. Over and above, there is better glycemic control with use of this two molecule, and that also decreases the genitourinary tract infection. So in the nutshell, we started this patient on fixed dose combination of Empalina, and I started with linagliptin 5 milligram and Empa milligram of 25 milligram, and we call this combination as a graceful combination. Now, grace is a mnemonic that can be remembered by all of you. G is for glycemia reduction. So glycemia reduction is rampant. It is up to 1.81%. Then R stands for renal benefit, renal protection, and renal safety, both. A is for adherence, that adherence gets improved and compliance also improved. And the C is for cardiovascular protection and cardiovascular safety and heart failure related protection and also heart failure related safety. E stands for error-free combination. So it's a weight reduction and also weight neutrality, one part, and another, there is protection or safety from hypoglycemia. So friends, I think we all are using this fixed dose combination in our practice, but my point of view is that it is a very efficacious, very safe molecule as a combination. So we must use this combination in more or more number of patients, we should find out the indication where we can use this molecule, this combination molecule. And again, the glycemic benefits are on over and above the monotherapy that has to be added. If another very important thing which I learned from my own practice, and also some trials have shown it, that if you add, suppose you are having baseline metformin, you added SGLT2 inhibitor, then on after 3 months or 6 months you added DPP-4 inhibitor. So this is the stage addition of DPP-4 inhibitor. You will not have that much benefit. Again, if you are having a DPP-4 plus metformin baseline, now you add SGLT2 inhibitor, again you will have some benefit, but not much. Exact benefit comes when you start with a fixed dose combination along with metformin. You add a start just with metformin, you add a fixed dose combination of Ampalena or a SGLT2 inhibitor and DPP-4 inhibitor. That is the thing, that is the how you can reap out the maximum benefit by using this fixed dose combination. So I will stop here, and if there are any questions, you can reach me out on my WhatsApp number, and also you can mail me at my email ID. Thank you.